Now we will go through the paper titled Effects of Alfaxalone, Propofol, and Isoflurane on Cerebral Blood Flow and Cerebrovascular Reactivity to Carbon Dioxide in Dogs. This is a pilot study. It's out of the Veterinary Journal from January 2023. It is open source, so we will read through the whole thing. We'll get started.
Effects of alfaxalone, propofol and isoflurane on cerebral blood flow and cerebrovascular reactivity to carbon dioxide in dogs, a pilot study. Abstract. Propofol total intravenous anesthesia is a common choice to anesthetize patients with increased intracranial pressure, reducing cerebral blood flow while maintaining cerebrovascular reactivity to CO2. Propofol and alfaxalone are commonly used for total intravenous anesthesia in dogs, but the effects of alfaxalone on cerebral blood flow and cerebrovascular reactivity to CO2 are unknown. Our hypothesis was that alfaxalone would not be significantly different to propofol, while isoflurane would increase cerebral blood flow and decrease cerebrovascular reactivity to CO2. 6 healthy hound dogs were evaluated in this randomized crossover trial. Dogs were anesthetized with 7.5 mg per kilogram propofol, 3 mg per kilogram alfaxalone or 8% sevoflurane, mechanically ventilated and maintained with propofol, alfaxalone or 1.7% end-tidal isoflurane, respectively, with 1 week washout between. Treatments: cerebral blood flow and cerebrovascular reactivity to CO2 during hypercapnic and hypocapnic challenges were measured using arterial spin labeling and blood oxygen level dependent magnetic resonance imaging sequences, respectively. Median normocapnic cerebral blood flow was significantly lower with alfaxalone compared to isoflurane. In the whole brain, 15.39 ml per minute 100 G versus 34.10 ml per minute per 100 G. The gray matter 14.57 ml per minute 100 G versus 32.37 ml per min/100 G. The caudal brain 15.47 ml. Min 100 G versus 36.85 ml per minute 100 G, and the temporal lobe gray matter 18.80 ml per minute per 100 G versus 43.32. Median hippocapnic cerebrovascular reactivity to CO2 was significantly higher for alfaxalone compared to isoflurane 8.85% per millimeter Hg versus 3.90% per millimeter Hg. Alfaxalone maintained lower cerebral blood flow and higher hippocapnic cerebrovascular reactivity to CO2 than isoflurane.
Just to go through the results of the abstract, as it could be hard to follow, just to summarize, blood flow rate was approximately half that with alfaxalone compared to isoflurane in all parts of the brain, and the flow increased by approximately 8% with alfaxalone when exposed to carbon dioxide compared to only 3.9% with isoflurane. I'm not sure how this compares to propofol, but hopefully we will get more details as we go through the article. Let's continue.
Introduction. The ideal anesthetic plan for patients at risk of increased intracranial pressure should decrease the cerebral metabolic rate and decrease cerebral blood flow, consequently decreasing ICP and improving cerebral perfusion pressure overall, while also maintaining cerebrovascular reactivity to carbon dioxide. It should also ensure hemodynamic stability and a quick recovery, to allow a prompt assessment by the neurologist. Currently, propofol total intravenous anesthesia is the most common choice for the safety of these patients. Propofol, however, causes significant cardiovascular and respiratory depression. Alfaxalone is a neuroactive steroid and GABA agonist with a high therapeutic index which has been reported to potentially cause less cardiovascular and respiratory depression compared to propofol. Thus, alfaxalone could be a safe and effective option for patients who require anesthesia and suffer from intracranial disease. Although both propofol and alfaxalone are commonly used as general anesthetics for TIV in dogs, the effects of alfaxalone on CPF and CVR, CO2 are unknown. The aim of this study was to compare the effect of alfaxalone, propofol and isoflurane on CPF and CVR, CO2 using 2 functional magnetic resonance imaging techniques, arterial spin labeling and blood oxygen level dependent sequences, to determine whether alfaxalone could be an ideal and safe anesthetic agent for patients at risk of increased ICP. Arterial spin labeling is used to derive CBF by magnetically labeling the incoming arterial blood and using it as an endogenous diffusible tracer. A time series of pairs of labeled and unlabeled images are acquired and subtraction between the 2 produces a signal proportional to the tissue perfusion. Blood oxygen level dependent MRI instead uses the different photomagnetic properties of oxyhemoglobin and deoxyhemoglobin to detect dynamic changes in cerebral perfusion, allowing information to be gathered on the reactivity of the cerebral vasculature to changes in the arterial partial pressure of carbon dioxide. Both sequences are completely non-invasive, using no exogenous contrast. Our hypothesis was that dogs anesthetized with either alfaxalone or propofol when administered as an intravenous constant rate infusion would not experience significantly different CPF and CVR, CO2, while dogs anesthetized with isoflurane would experience higher CPF and lower CVR, CO2. Materials and methods. This prospective masked randomized cross over trial was approved by the North Carolina State University IACUC. 6 healthy mixed breed dogs were evaluated in this crossover study. No sample size calculation was performed as this was a pilot study. The dogs were randomly allocated to 3 groups: isoflurane, propofol and alfaxalone, with a washout period of at least 7 days between treatments and with a minimum of a month washout period from previous studies. The isoflurane group served as our positive control group because the performance of MRI in awake dogs was not an option at our institution. The inclusion of the isoflurane group allowed us to validate our results with a treatment which produced predictable results. Randomization of treatment order was performed using an internet randomization tool. Each dog underwent a physical examination, including a neurological examination performed by a board-certified veterinary neurologist, a complete blood count and blood biochemistry profile. The dogs were excluded if not deemed healthy. By these standards, dogs were housed in run size to meet standards for housing of research animals, with a 12H light/dark cycle. Dogs were allowed out of their housing for playtime at least once daily, either in a play yard or in a room dependent on weather conditions. The dogs were daily fed a commercially available diet but were fasted for at least 8H prior to the start of the anesthetic event, maintaining free access to water. During the study day, dogs were transported in mobile cages to the MRI suite preparation room, where an IV catheter was aseptically placed, and a non-invasive blood pressure measurement taken. Anesthetic protocol. General anesthesia was induced with 7.5 mg per kilogram propofol in the propofol group or 3 mg per kilogram alfaxalone in the alfaxalone group. Both drugs were administered IV over a period of 60 s, and anesthesia was maintained with a propofol CRI at 400 per kilogram per min or alfaxalone CRI at 150 per kilogram per minute, using a syringe driver. Dogs in the isoflurane group were induced via an induction mask with 8% sevoflurane and maintained with isoflurane at an end-tidal isoflurane of 1.7%. Sevoflurane has been reported as the least irritant inhalation anesthetic, making the mask induction without pre-medication smoother and less unpleasant. All the dogs' tracheas were intubated using an endotracheal tube of the appropriate size and administered 100% oxygen. After induction and intubation, the dogs were instrumented with electrocardiogram, non-invasive blood pressure, pulse oximetry, side stream capnography, and an arterial catheter placed in a dorsal pedal artery. Monitoring of the electrocardiogram, peripheral capillary oxygen saturation, end-tidal carbon dioxide, non-invasive blood pressure and invasive blood pressure was performed throughout the anesthetic event, using a portable monitor in the MRI preparation room and an MRI-compatible monitor once the dog was moved into the magnet. End-tidal carbon dioxide concentration, end-tidal isoflurane and end-tidal sevoflurane concentrations were also monitored with a monitor located outside the Faraday cage. The gas analyzer module was calibrated at the beginning of each study day using the manufacturer's calibration gas. Bubble wrap in conjunction with blankets were used to cover the dogs to prevent heat loss. Temperature was measured with a handheld digital thermometer before and after the MRI. Earplugs were placed in both ears for noise protection. After being instrumented, the dogs were placed in dorsal recumbrances in the MRI scanner and mechanically ventilated with an MRI-compatible ventilator to maintain EtCO2 within the normocapnic range. Hypercapnia and hypocapnia were defined as an EtCO2 above and below this reference range, respectively, after at least 30 minutes of equilibration, before starting fMRI sequences, and after end-tidal isoflurane was 1.7% and end-tidal sevoflurane 0.0% in group isoflurane. An arterial blood sample was taken with an arterial blood gas syringe to quantify PaCO2, PAX cell volume and total solids. MRI and analysis. The investigator analyzing the functional MRI images was not involved with drug preparation or administration and was unaware of the treatment received by the dogs. Drug preparation, administration and general anesthesia was performed by the same investigator. A 3 Tesla MRI scanner and 18-channel knee coil were used for image acquisition. A free and open source code software and post-processing software were used for anatomical MRI image analysis and cerebral segmentation respectively. FSL software was used for functional MRI data post-processing. Each group underwent an MRI scan using ASL first, and then BOLD sequences. The ASL sequences were acquired with the dog maintained at normocapnia. The 2D ASL sequence used provided calibrated CPF perfusion values directly from the scanner. BOLD sequences were then acquired during an hypercapnic challenge followed by an hypocapnic challenge. To perform the hypercapnic challenge, the settings of the mechanical ventilator were adjusted to maintain normocapnia for the first 2 minutes of the scan and then hypercapnia for the next 2 minutes, and this cycle was repeated 5 times. The same was repeated for the hypocapnic challenge, starting with normocapnia and sequentially changing ventilation settings to obtain hypercapnia. Once the MRI acquisition was complete, the dogs were recovered in the MRI preparation room, a rectal temperature was obtained, SpO2 and capnography were monitored. Once the endotracheal tube was removed, temperature, pulse rate and respiratory rate were recorded. The dogs were directly observed until deemed normothermic and able to stand on their own. Statistical analysis. All statistical analyses were performed with Stata IC 14.2 for MAC. The PaEtCO2 gradient was calculated as the arterial to end-tidal carbon dioxide pressure difference. Data were tested for normality using Shapiro-Wilk normality test and graphically using histogram distribution and the norm function in Stata. Data were reported as mean plus or minus ST or median if normally and not normally distributed, respectively. Physiologic differences between groups at baseline, PaEtCO2 gradient, EtCO2 and CVR, CO2 during the hypercapnic and hypocapnic challenges. Differences in anesthesia times and scan times were compared between groups using one-way repeated measures ANOVA or Friedman's test followed by Wilcox and signed rank test, as appropriate. Bonferroni's correction was applied as appropriate for multiple post-hoc comparison. The cerebrovascular reactivity to carbon dioxide was defined as the percentage change in cerebral perfusion from baseline per change in mmHg of EtCO2. Changes in heart rate over time were analyzed using mixed effect linear model on ranks with dog as a random effect, time, treatment and their interaction as fixed effects and the residual covariance set to unstructured. Since measurements in blood pressure could not be assumed to be normally distributed, the outcome was rank transformed prior to be analyzed by mixed effect linear model, as previously described. The normal distribution of the standardized residuals was assessed with the Shapiro-Wilk normality test and graphically with the quantile plot and histogram. Statistical significance was set at alpha equals 0.05. Results. This manuscript conforms to the arrived guidelines 2.0. The 6 dogs enrolled in this study were median 3.6 years and weighed 27.45 kilograms. The median PCV at the beginning of each study were 48%, 45.5% and 48% in the propofol, alfaxalone and isoflurane groups respectively, and were not significantly different between groups. The median PaET-CO2 gradient was 3.5 mm Hg, 4.5 mm Hg and 3 mm Hg in the propofol, alfaxalone and isoflurane groups respectively, with no statistically significant difference between groups. The median anesthesia time was 120 minutes, 118 minutes and 122.5 minutes in the propofol, alfaxalone and isoflurane groups respectively. The median scan time was 95 minutes, 93 minutes and 100 minutes. In the propofol, alfaxalone and isoflurane groups respectively, there was no statistically significant difference in anesthesia time or scan time between groups. There was no significant difference in heart rate between groups over time. However, dogs receiving alfaxalone infusion maintained overall significantly higher HR, while dogs anesthetized with isoflurane recorded overall significantly lower HR compared to the propofol group. There was no significant difference in systolic, mean or diastolic arterial pressure among groups over time. Dogs experienced overall significantly lower systolic arterial pressure when receiving alfaxalone infusion or isoflurane compared to propofol infusion. In addition, dogs recorded an overall significantly lower mean arterial pressure when receiving isoflurane median 75 mm Hg, p. 0.01, compared to propofol infusion. However, these differences were not considered clinically relevant. The median temperature differences between induction and the end of the scan were 0.55 C, 0.60 C and 0.70 C in the propofol, alfaxalone and isoflurane groups respectively. There was no statistically significant difference in temperature change before and after scans between groups. Based on the ASL imaging, the whole brain, gray matter, caudal brain, and the gray matter of the temporal lobe of dogs in group alfaxalone had a median CBF significantly lower than those in group isoflurane. The median CBF in the rostral brain and in the frontal, parietal, and occipital lobes gray matter was not statistically different among groups. The mean plus or minus SD baseline ETCO2 for the hypercapnic challenge were 39.67 plus or minus 1.63 mm Hg, 38.67 plus or minus 137 mm Hg and 40.33 plus or minus 136 mm Hg in the propofol, alfaxalone and isoflurane groups, respectively. There was neither a statistically nor clinically significant difference in baseline ETCO2 between groups. The mean plus or minus SD ETCO2 reached at the peak of the hypercapnic challenge was 50.67 plus or minus 0.82 mm Hg, 52 plus or minus 210 mmHg, and 51.5 plus or minus 1.76 mmHg in the propofol, alfaxalone and isoflurane groups, respectively. There was neither a statistically nor clinically significant difference in maximal ETCO2 between groups. During the hypercapnic challenge, the increase in bold CVR, CO2 was clinically relevant but did not reach statistical significance. Median baseline ETCO2 for the hypocapnic challenge was 40.5 mm Hg in the propofol group, 39.5 mm Hg in the alfaxalone group and 42 mm Hg in the isoflurane group. The median ETCO2 at the peak of the hypocapnic challenge was 30 mm Hg in group propofol, 29 mm Hg in group alfaxalone and 27 mm Hg in group isoflurane. During the hypocapnic challenge, the CVR, CO2 was significantly lower in group isoflurane than in group alfaxalone. Discussion. In this study, alfaxalone had a reduced CPF in the whole brain, gray matter, caudal brain and the gray matter of the temporal lobe compared to isoflurane, and exhibited more CVR, CO2 during the hypocapnic challenge, compared to both propofol and isoflurane. This may be an advantage when performing anesthesia in a patient at risk of increased ICP, especially when PaCO2 manipulation is performed, leading to a greater CPF reduction per each mmHg of ETCO2 decrease, particularly in the hypocapnic realm. Although propofol performed similarly to alfaxalone in the whole brain CPF and CVR, CO2 during the hypocapnic challenge, the difference between propofol and isoflurane was not statistically significant. It is possible that the small number of dogs did not confer enough power to our study to make that change statistically significant. However, the absence of a statistically significant difference between treatments in the CVR, CO2 hypercapnic challenge was not unexpected. This has been reported in previous studies, proving that different anesthetic agents cause the cerebral vasculature to react differently during hypocapnic versus hypercapnic states. In the current study, other factors potentially affecting CPF such as body temperature, blood viscosity, PAO2, and mean arterial pressure were considered. The cerebral metabolic rate, and consequently CBF, decreases by approximately 6 to 7% per degree Celsius reduction in body temperature. Rectal temperature was only measured at 2 time points in this study, before and after the MRI scans, although this may be considered a limitation. There was only a minimal intra-subject change with no statistically significant difference in body temperature between groups. The effect of PCV, the most important factor affecting blood viscosity, on CBF has been debated in the literature. The changes appear to be associated with a decrease in delivery of oxygen rather than viscosity, and therefore except at low levels, PCV does not seem to affect CBF. In this study, PCV was always within normal limits, and there was no significant difference between the groups. The effect of PAO2 on CBF has been extensively studied, and it is commonly accepted that when PAO2 decreases below 50 to 60 mm Hg, the CBF increases considerably. Additionally, more recent studies demonstrate that normobaric administration of 100% O2 has minimal to no effect on CBF. In the present study, dogs were constantly mechanically ventilated with 100% O2, SpO2 was continuously monitored, and although PAO2 was only measured at one time point, in all cases it was greater than 400 mm Hg, and a significant difference between the groups could not be appreciated. The authors used EtCO2 as a surrogate of PaCO2, another potential limitation of this study. Although many studies have investigated the relationship between the two, very few included patients where there were no hemodynamic changes or severe lung changes. Such studies have shown that in a mechanically ventilated patient, the gradient between EtCO2 and PaCO2 is smaller, almost matching, at low dead space values and increases as the dead space gets larger. This varies between patients, however. Once established, the intra-subject trend remains stable over time for more than 4H, well, above the anesthesia time in our study, suggesting that EtCO2 could be used as a non-invasive reliable guide to estimate PaCO2 in our dog population. Arterial spin labeling has been used for decades in human medicine and validated against a wide range of perfusion measuring techniques, including the gold standard for brain perfusion imaging H2, 15O, positron emission tomography. Blood oxygen level dependent MRI has been extensively used in both humans and dogs, but ASL has not previously been validated in dogs. Although the authors recognize this could be a limitation, in this study the same technique was used in all three groups and the CPF values were used only to evaluate differences between treatments, as it was not in the objective of the study to provide absolute perfusion results. Lastly, lack of sample size calculation is another limitation of this study. This is a pilot study, and further investigation is needed to both confirm and expand on our findings. Conclusions. The CBF was lower in CVR, CO2 was higher in dogs when anesthetized with alfaxalone TIVA, as compared to isoflurane. Alfaxalone may prove a viable alternative to propofol for TIVA in patients at risk of increased intracranial pressure.
Overall, I am quite happy that this paper was performed, as it is something that I have been wondering about for quite some time. Now we just need to know the effects of alfaxalone on EEG. But going through the paper, I feel the study was well designed, especially as a pilot study. The only thing that really could have been improved upon is if they either had more dogs or if they were able to perform PET perfusion imaging. At most places, we don't have access to PET, so arterial spin labeling is a very reasonable option. Although it can underestimate the degree of cerebral perfusion compared to PET or SPEC, findings seem to be consistent. In other words, if we truly wanted to know the amount of perfusion that could lead to cerebral damage, arterial spin labeling might not be the best way to determine that, but to compare the amount of perfusion from one patient from one drug to another drug, in other words, looking at a ratio, arterial spin labeling with MRI is a very reasonable option. Therefore, again, the design of the study seems to be very reasonable and adequate to answer the hypothesis. As I mentioned with the abstract, I was wanting more information on propofol, and the paper provided that. Looking at Table 1, I find it to be the most helpful, and they did find that there was a significant difference in the degree of perfusion from propofol and alfaxalone compared to isoflurane, with isoflurane being higher in the amount of perfusion compared to the other two drugs. Additionally, alfaxalone was lower in every category compared to propofol, although it doesn't seem that it was significantly different. And Figure 1 does a nice job highlighting the findings, as you can see here. Looking at Table 2, if a patient was hypercapnic, there was not a significant difference in the change of arterial flow, and this is also highlighted in A of Figure 2, as you can see on the screen now. However, when the patient was hypocapnic, there was a significant change in cerebral perfusion, and this is shown in Figure 2B, again shown on the screen right now, with both propofol and alfaxalone compared to isoflurane. This is also shown in Figure 3, just in candlestick form. So nothing really controversial about this paper. The findings are as expected, but reality can often be different than what is expected, so it's nice to have this information and confirmation. A couple of comments. Firstly, we don't know how this reflects dogs with intracranial disease. It stands to reason that alfaxalone would be safe in dogs with intracranial disease, but we can't say for certain just based on the design of the study. Additionally, dogs in the isoflurane group were induced with sevoflurane, so it is unknown if this could have affected the results in the isoflurane group. We can't say for certain, but if there was a sevoflurane group, that might be helpful to have that information too. Or they also could have induced with propofol that maintained on isoflurane. I get why the study was designed the way that it was, as induction with isoflurane alone can be quite dramatic on the patient, but it's just something to keep in mind. That said, my takeaway is that if you have a dog with cardiovascular disease that might have intracranial disease as well, alfaxalone seems like a very reasonable drug for induction and maintenance. Those are my thoughts. Thank you.